Good afternoon. Welcome to today's Grand Rounds presentation. Please remember to fill out the attendance records, and also please remember to fill out the program evaluations, and if you could give us any ideas in regards to future topics, future speakers, the CME committee would be appreciative. Today it's my pleasure to introduce Dr. Debra Prow, who's our speaker. Dr. Prow is board certified in internal medicine and oncology. She did her training at MD Anderson, and she's a member of the Department of Hematology-Oncology at McFarland and Mary Greeley, and she's here today to review evaluation and management of hematologic-oncologic emergencies. And please join me in welcoming Dr. Prow.
Yes, sir. Good morning. For those of you who don't know me, this is an interactive program. You can count on your friends and neighbors who accompany you today to help you out if you get stuck. And I'd like to start by thanking everyone for the help in the care of our hematologic and oncologic patients, because this is a team approach, and we certainly can't take care of them by ourselves. Let's see if we get. So these are the objectives that you guys have seen on the prior slides. And if you have a handout, if you please turn it upside down and stop looking at it, it will make life much more interesting today. This is a format, as I said, it's interactive, so everybody gets an opportunity to participate. These are case presentations over the last 20 years, so some of the data has changed and been updated. We'll start with a history, a physical exam, some lab and a pertinent radiology evaluation. And then you guys' part is to give me a differential diagnosis, how you would treat this patient, and then I'll tell you what actually happened to them. So this is Dr. Partridge's case. Good morning, sir. This is a 64-year-old Caucasian male who has an 80-pack-year history of tobacco use. And he comes to his PCP in a wheelchair. His back hurts. He can't urinate, and he has constipation. He's had trouble walking for the last 10 days. Those are his vital signs. You can see that his O2 sat is low at room air. He's unaccompanied, has no social support. He has decreased breath sounds at his left base. His belly is somewhat distended. You can tell that his bladder is full of urine on your physical exam. He has an enlarged prostate and decreased rectal tone, and he's got a sensory level that's present and bilateral leg weakness. So what's that make you think of, sir? Yeah. So what do you think that might be from?
You're an oncologist, so maybe a tumor.
Yeah, that would be true. But I have to deviate from that and just tell you a very short story. 18-year-old kid who was herding cows in Mexico came in with the exact same picture, and when he went to the OR, there was a cactus needle in his spine that has abscessed. So I might put that in there next time, and then you'd be fooled, because that would be a non-oncologic outcome. So he's got some anemia. His ABG shows that he is somewhat hypoxemic. He's got a little bit of elevation in his creatinine, but otherwise not too bad. He's got a chest x-ray with a mass in his right upper lobe. So what other differential diagnoses can you come up with? Sarah, what else could this be besides cord compression that Dr. Partridge is talking about? Any other thoughts? Could be an abscess. Could be an abscess too. So it could be infectious. Could be TB with POTS, and I saw Dr. Hopkins somewhere up here. So if you didn't have a tissue diagnosis for this guy with a cord compression, would you be comfortable providing external beam radiation in this scenario?
No, I'd be calling the surgeon.
Go ahead.
We'd want to get him treated quickly as possible, but we want to do it right, and we'd want to get the tissue diagnosis first.
Yeah, because Does your radiation work well for infectious disease?
No, it doesn't.
Oh, so you don't want to be in that situation. So he could have a small cell lung cancer, a non-small cell lung cancer, or a non-lung primary tumor, or he could have a compression fracture of his spine pushing against his cord. Ooh, backwards. Don't look at that, Dr. Salty. This is a guy who comes in with a cord compression that we feel is most likely due to a lung cancer. He can't walk, his bladder's distended, he has no rectal tone. So if we make that assumption that it's a cord compression from his solid tumor, how are you going to treat him?
In emergency, I give him high-dose steroids right away. Admit him to the hospital, and you consult you and radiology-oncology, and spinal surgery, and see what is the best way to treat him.
How long do you think it takes not to be able to walk till you can reverse that with
Not
decompression?
long. I don't know what the time, but it's not long.
It's not long. He's been this way for 10 days. Do you think his chance will be that he can
10
be
days,
reversed? Probably not. So high-dose dexamethasone has been shown to be better than low dose. You also have your GI protection to monitor for high blood pressure, as well as diabetes, thrush, and mood changes that we see not infrequently. Who's a nurse? Raise your hand if you're a nurse. Oh, look at you guys. So cheap. You put in a Foley catheter, and you know he's got a distended bladder. How much urine are you going to let out at a time before you clamp it so that bladder doesn't decompress really fast and he bleeds? Tell me?
1,000 at the most.
Yeah, I like 500 because I'm kind of a conservative person. And then you clamp, let a little out, clamp, let a little out. Because it's really bad if that bladder totally decompresses and then you've got hemorrhage on top of all this other stuff that you got going on. And Emily and whoever's her helper running around, they run really fast, so. And then he needs a bowel program. He needs the rest of his imaging done as well. Neurosurgical evaluation is important. We need a tissue diagnosis and then radiation oncology evaluation. Dr. Ottoman, sir, it's such a pleasure to have you here today. If this were small cell, would this plan change?
I wouldn't be as concerned. I wouldn't be as concerned about trying to surgically debulk the guy and just go to radiation.
And can you tell the audience why we changed our plan
Just
that way?
that small cells are very radiosensitive.
Yeah, and chemosensitive, so we can
Chemosensitive, too.
do a little bit better there. So this gentleman had a non-small cell lung cancer with a T10 cord compression. He received radiation therapy but had no neurologic improvement and ended up going to a VA nursing home with a DNR status. Dr. Arbulu, how are you this evening? It's morning. Do you think if he would have went under early surgery that his outcome would have been better in light of the fact that he didn't walk for 10 days before he presented?
It's on.
I'm not. I mean, I was thinking. I'm not sure about the non-small cell lung cancer though. I don't know how that changes a prognosis as opposed to just from what Dr. Odeman said, right? Like this one, barely remember, is less responsive, right? So probably in this particular case, you would have a better prognosis if you operated early. That's my guess.
If he would have presented in the first 24 to 48 hours, then his chance to recover his ability to walk would be much greater than when he presented, 10 days later. So that's a point that if folks present earlier, they might have a greater ability to ambulate, to be able to walk out of the hospital. All right, let's see. Dr. Pogue, good morning. This is an interactive problem. I'm going to read a minute, but this is your case. This is a 54-year-old Caucasian male who presented to MD Anderson for a second opinion regarding his renal cell carcinoma. He's post-op from a radical nephrectomy for a Furman grade 4, which means it's an aggressive cancer, but a T2, so a stage 1. He comes in with a 3-day history of a headache and a 24-hour history of vomiting, and he's throwing up right in front of you. What's the first thing you think of?
How many days post-op?
Alrighty, he was post-op about 3 months, okay? And that'll come in a little bit when I show you the film and stuff results. He's got a little bit of a fever, 99. He's a sick-looking guy when you look at him. He's got a fiance and a daughter that's with him. His nephrectomy scar is well healed, and he really doesn't have any neurologic symptoms other than him holding his head and he's throwing up at you. And he's got full range of motion of his neck. He had 3 months ago was the time of his nephrectomy, which he had imaging that showed no other sites of disease. He has almost no abnormalities in his CBC, and his electrolytes are fairly stable outside of a little bit of volume depletion. And his chest x-ray is normal. Tell me, what is your differential?
I'd be concerned about increased intracranial pressure. He has headaches and nausea, and might want to do a fundoscopic exam if I still could at this point, years after training.
Mm-hmm. And what would you be looking for on that fundoscopic exam?
Papilledema.
Yep, and what does that equal?
Increased intracranial pressure.
Yep.
So, you might think of course, metastasis to the brain. That's my number one that I'm coming up with right now.
Okay, infectious disease things are always an issue.
Right.
So he could have a benign headache with a viral syndrome or some infectious thing. He could have really bad sinus infection or migraine headaches. Or, like Dr. Partridge said, this is kind of a hemonc talk, so Mets are always a concern to us. If we make that assumption that it's metastatic disease to the brain, hi, Jody. You're now a doc. What are you going to do with this guy? You have friends. You can pick on one of your friends to help you.
Dr. Partridge is closest to me. He can answer again, maybe.
You mumbled. Did you say MRI of the brain?
I said MRI of the brain.
Oh, okay.
Thank you.
Oh, but the MRI scanner is backed up. You can't get in for
I'm
a
glad
couple
because
of hours.
I can read CTs much better than MRIs.
That's so cheating. He has a drug allergy to IV contrast, so now you got to pre-medicate him.
I don't know. I'm probably too old. Steroids and Benadryl and
Very nice. And something for the nausea, maybe.
some Zofran.
Yeah. So some dexamethasone would be important. In the old days, a long time ago, anybody who presented with brain mets that we were worried about got anti-seizure medicine. And then Mayo put out a big article that said that that didn't really provide benefit if you've never had a seizure before. So we don't always routinely do that. And then we need our imaging studies to see what's going on in his brain and restage him, and then look at the role of neurosurgery and radiation oncology. And I think I must have scared Dr. Hopkins off because he left. You got patients? So you work with, tell me your name? Aha! Sherry. I bet I talked to you on the phone a lot, huh?
Oh, yeah.
Okay. So he had a right frontal parietal solitary met. And tell me, from a rad-onc standpoint, is renal cell carcinoma very radiosensitive?
Not as much, yeah.
Not as much as some other
Yeah.
diseases. So if you have the ability to resect a renal cell that may be a solitary site of disease, that's a really good thing, because radiation, and until the last probably 5 to 10 years, we didn't have good systemic therapy that we do now. So he underwent a craniotomy, and he underwent weaning off of his steroids. And do you think he would have had, this is a Dr. Ottoman question, that he would have had better outcome if radiation was given post-op if this is his only site of disease?
Oh, is this his only site?
Yeah.
Yes, he would.
Yeah. So in the stereotactic radiosurgery, you guys know what that is? Can you explain that to everybody for me, just real short? No, because that's a really good thing. Stereotactic versus whole brain versus both.
In a stereotactic setting, we immobilize the patient. Typically, they're in like a vacuum type bag, their entire body. We target very small areas with very, very small margin around that area, and we usually target it with anywhere from 13, 15, maybe 20 beams coming in from multiple directions and angles, and the goal is to radiate that very small area with very little margin around it getting treated as well. And very complex planning that Samantha and I can take care of for that. To treat that patient, they come in, very few treatments, sometimes only one shot, maybe 3, as many as 5 in some instances, depending on the size of the lesion, kind of determines the daily dose that we give. The daily dose that they would get is sometimes 4 to 5 times the daily dose that we would give a normal fractionated course of treatment. And the treatment takes about an hour at least. And mostly because of the imaging that's required to make sure that we are on target with a sub-millimeter accuracy.
And do you put them in halos anymore? Because we used to get, your skull was screwed into a halo.
We don't, if we're doing stereotactic of the brain, it's a very rigid mask system, but it's not screwed into their skull, no.
So that's a big benefit for that versus gamma knife, so to quote. Good morning, Dr. Grangenet. You ready? All right. This is a 46-year-old African-American male who came to his local ER where you were moonlighting one night with right leg swelling and pain, 24 hours of chest pain, shortness of breath. His family history is positive significantly for prostate cancer, with his dad and 2 uncles dying before they were 50 years old. Tell me your thoughts.
First of all, my first concern is that he would have a pulmonary embolism.
From what might that be
from? From a DVT in his right leg.
Yeah. So he's got a fever. His O2 sat is down. He's a really sick-looking guy. He's got a wife. He's kind of sitting on a chair, huffing and puffing. And they have 2 twins, boys, 14 months old. So the leg is markedly larger than the left. It's tender. His GU exam, he has a markedly indurated prostate with extension, and he's got a rub on his chest. So what would you like?
A CT, stat CT of the chest with contrast.
But you don't know his kidney function. Does that bother you?
No, yeah, I suppose that would bother me a little bit. So we better do some blood tests, including blood count, metabolic panel. I suppose the PSA would be on there somewhere.
You bet that PSA is on there. It's 28. He's got anemia, and his BUN and creatinine are okay. His D-dimer is elevated. His bilateral pulmonary emboli and his lower extremity Doppler is positive. When would you call your cardiology colleagues for concern of thrombolytics?
Now.
Okay. Do we have any cardiology folks around? Nobody claiming. So the differential is what you said, that he likely has an adenocarcinoma of his prostate with a hypercoagulable state that we see not uncommonly at all, with DVT and PE. He could have a hereditary hypercoagulable state on top of this or by itself as well that we would work up. So how would you treat this guy?
I would put him on a blood thinner.
Which one are you going to use?
Lovenox.
Okay. How are you going to dose it?
1 milligram per kilogram, Q12 hours.
Okay.
And then I'd get an echo on him pretty quickly too, I think, just to make sure he's not having the right heart
strain
backing up pretty badly.
What are you going to do about
ICU,
his cancer?
For sure. Call an oncologist.
Yeah. So are you going to call an oncologist or a urologist? Or both?
Can he pee?
Yes, he can urinate.
I would probably start with an oncologist, because I think the urologist may be necessary later, but I would think that your input as far as which road to go down would be.
Yeah, the benefit we have from consulting our urologic docs is so that we can get a biopsy if we're targeting the prostate. So he got anticoagulated with heparin. It was before the days of low molecular weight heparin, and was provided supplemental oxygen. His Gleason score is 4 + 5 = 9, which is high grade. So he underwent staging evaluation. So he got anticoagulation. He got total androgen ablation. What about his twins? They're 14 months old.
When they should become screened? You mean when they should get screened? You mean young?
Yeah. So this guy's like
how
in
old?
his 47.
30?
Yeah, or 40.
40?
Somewhere around
35?
40.
Yeah, I don't know.
The role of thrombophlebitics thrombolytics when you talk to the cardiology guys who actually do that, unless there's a saddle embolism or there is severe right heart strain, they're not overly excited to use those. Plus, then you have to go through all the stuff, did they have a GI bleed recently or those kind of things. There are presently a whole lot of anticoagulation options that are now FDA approved that we haven't had in the past. You've got your heparins or heparinoids, you've got your coumadins. You now have oral 10A inhibitors. You need to know that those can't be reversed, and thrombin inhibitors. So there's more there to work with. All right. Who else is a doc here I haven't picked on? Is that a friend of mine in the very back row? Yeah. That doesn't prevent you from getting the next case.
I understand. Thank you. And I'm chewing. Is that a problem? Is that
not a problem at all.
The MTHFR, the genetic test with the most unfortunate acronym. Are we still doing that? Larry, you'd given a talk where I thought the yield on that, the utility of that was to drop to 0. Am I wrong?
Yeah, the data from primarily the Scandinavian countries are that the mutation itself has no decreased risk of thrombosis. So it used to be thought that an elevated homocysteine level
was the sort of the path that led to thrombosis, and so some people advocate just doing a fasting homocysteine level and leave it at that if they should be elevated. It's quite clear that the mutation in and of itself has no thrombotic risk associated with it, and unless there's something very unusual, there's probably little to be gained by checking for that specifically.
The homocysteine is nice because if it's elevated, how we treat that is with folic acid. Sarah, do you have a comment from a genetic standpoint about MTHFR versus prothrombin gene mutation versus factor V leading?
I mean, I agree with Dr. Ottoman. There's the MTHFR is kind of meaningless except for if the homocysteine level is elevated. not so with the factor V Leiden and the prothrombin.
Gene mutations. Good point. All right, you ready, sir?
I'm ready.
Okay. This is a 54-year-old Pakistani male who comes to the ER in the middle of the night while you're moonlighting as a resident. And he is throwing up blood and says, oh, I have this bleeding disorder. And he looks sick, and then he vomits blood right in front of you. What's your thoughts?
I'm not going to be quite as gung-ho about transfusion as I was prior to Dr. Ottoman's last grand rounds. But I want to know, is he hemodynamically stable? What are his vital signs?
His blood pressure is 90/50. His heart rate's 145. His SAT's okay. He's got a little bit of a temperature. He's pale. He's sick looking. He's got no petechia. He's tachycardic. His belly's kind of quiet. His rectal exam shows melena that's grossly guaiac positive. And he's got a bunch of chronic changes in his knee joints. They're all big and deformed.
So I'm thinking he's a hemophiliac, perhaps with the bad knees, and I'm thinking that if his hemoglobin is anything shy of 7, for sure he gets blood. And if he's actively bleeding in front of me, I might just type and cross him and be ready to get blood into him and hope that Larry doesn't find out.
So, nothing's easy in life. His white count's 13,000, his hemoglobin's 7, his platelets are 190. His PT is 18 with a control of 12, and his PTT is 47 with a control of 25. And his INR is 2.9, his chemistries are okay.
And he comes to me on any medicines by chance?
He doesn't know. I mean,
Doesn't know.
he couldn't even tell me what his disease was. And most hemophiliacs, they can tell you, this is my disease, this is my replacement, this is what I do, this is my history. He couldn't say anything.
Well, then I'm thinking he definitely is getting blood and lots of fluids. We're going to, support him.
Yeah, he is hypotensive and tachycardic, and he's older, he's in his 60s. So you could have a GI bleed secondary to hemophilia, that's kind of where we're trending, or he could have a GI bleed associated with a lot of other causes. Could have liver failure, DIC. He can be taking a bunch of complementary and alternative medicines. The herb with the last name of Montana, if you eat a bunch of that, will cause problems as well. He could have been doing that for his knees, those kind of things. Oh, I cheated.
That's
Don't
okay.
Look at that. Dang. All right, what do you want next?
I think I want a hematologist to see this guy.
Yeah.
And I'm going to hope that when I type into Epic hematology panel or hemophilia panel that it spits out, one of those, lab orders for dummies kind of things, because I want to know what kind of hemophilia he has. So I'm probably, if he's an active GI bleeder, going to invite my GI friends to the party to see if there's some means of getting hemostasis on him. It sounds like, clearly he's got an upper GI bleed and he could be bleeding from other places. I'm going to try to hunt down what drugs he's on. So
that can be a challenge sometimes. So we get a 1-to-1 mix to see if he corrects, because we want to know whether or not he has a factor deficiency or an inhibitor. Mm-hmm. Dr. Granginet, which one would you like him to have?
Which factor?
No, would you rather have a factor deficiency or an inhibitor to a factor?
Deficiency.
Yeah, see, I give you such easy stuff. All right, so then we want levels and factor replacement and supportive care. So those are the things. This gentleman had a hemophilia A. He had a factor 8 deficiency. The half-life of the replacement is 8 to 12 hours. And you've got a little graph thing that tells you, how much factor you need to replace. This guy is actually in a life-threatening situation. For every unit per kilogram of weight, you get a 2% increase. So the pharmacy here is really good to help you calculate doses. and then you need repeat doses because it gets broken down and used. In Christmas disease or factor IX deficiency, the replacement is a little bit different. This is not what this gentleman had. I can't remember all these. Maybe Dr. Ottoman remembers them all, but I've got them in a little cheat sheet to know because we don't generally use these replacements very often. So this gentleman had a factor VIII deficiency. It resolved with replacement therapy, blood products, and supportive care. So now, Sarah, what do we need to do? Do people know what you do on the side? Your side job is?
Genetic education.
So we have Mary Ellen, who does our genetic screening and counseling for most of our solid diseases, and Sarah, who does the hematologic genetic counseling and helping with education there. And then they both help with both things at other times. So now you got a guy with hemophilia. What are you going to do with his family?
We're going to test them.
Okay.
I have a question. I'm holding the microphone. The last guy, the prostate cancer people. I remember hearing, I know there is some male manifestation of cancers in the BRCA people. Are there other genetic, these people were black, they don't sound like Ashkenazi Jews. Are there any other screening tests by way, that seems like an awful lot of prostate cancer in a family.
Sarah?
One of the...
Run, Emily, run.
The BRCA gene, and also African American males also have a higher incidence of prostate cancer. But yeah, prostate cancer is elevated incidence in BRCA 1 and 2.
Would you get any of that stuff, Deb? Or anybody?
I don't think that would insurance probably wouldn't pay for that.
Okay.
For right, Mary Ellen, for prostate cancer, you would check their family history and see if there was breast and ovarian cancer, and then start figuring out who you'd test from there.
Yes, sir, Dr. Salty.
I have a question about the hemophilia. Do you test the males only, or there's a benefit from testing the females as well?
Sarah?
I need that back.
This isn't something I do a lot, but I think it's males only.
Correct. And so the offspring of the females. Any other thoughts?
Just put a little plug in for prudent lab utilization here. In a case like this, you could spend literally tens of thousands of dollars in testing. In today's reality of electronic medical records, it'd probably be cheaper to make sure to get his medical records from somewhere in the past.
He came from Pakistan.
Get them, because you'd be surprised what records you can get nowadays. And with someone like this, you don't need to know if he has Christmas disease or classic hemophilia tonight, because you're going to support him. But if you can get medical records, you can solve a lot of these problems and not have to do repeat testing. So just a little plug for the laboratory.
Prevention, control, and education can improve outcomes. And I don't know if there's a hemophilia center that's located around here. I guess the University or Mayo may have a group.
The University of Iowa is the designated hemophilia center for the state of Iowa.
Okay. So that would be where we would hopefully get those people into. All right, Dr. Whiter, this is your case. You get to be one of us now. You ready?
I even have a medical license, believe it or not.
This is a 64-year-old Caucasian male with a history of squamous cell carcinoma of the lung and metastatic disease to the bones, who presented to his primary care provider with his wife and his daughter telling the doc, telling you that this guy's not thinking right, he's urinating all the time, he's got constipation, and he's just not doing well. What's that make you think of as far as a differential?
Well, with the with that history of squamous cancer of the lung and cognitive changes that sound like they're new. I mean, I make sure they're new and not something that's chronic for him. And that dizziness, more urination. I'm a little concerned about a paraneoplastic syndrome, maybe syndrome of inappropriate ADH secretion. Those would be things I would think about, particularly with that history. Again, he could have metastasis to the brain, but he could have secondary problems in the brain just due to his paraneoplastic syndrome.
So his blood pressure was down a little bit, his heart rate's up a bit, he looks sick. He can only answer as to his name, but otherwise wasn't under any duress per se. He had decreased breath sounds at his bases, some tenderness over his liver, and he had hepatomegaly with some distension, and he really couldn't walk very safely. It took 2 people to try and get him up to walk him, and he's really just confused. What would you like?
I'd probably get basic metabolic panel and CBC, and I'd like to collect some urine to see what his sodium excretion is.
So his white count's 20,000, his hemoglobin's 14, his platelet count's a little low at 110. His albumin's low at 1.9, and his corrected calcium is 18.6. I got a chest x-ray too. He has decreased lung volumes and his right apical mass with bilateral metastatic disease. So now what's your differential?
Well, that calcium is sky high, so he's got a hypercalcemic syndrome, and again, that could be due to a paraneoplastic syndrome, or it could be due to some type of parathyroid adenoma. I mean, common things happen commonly together, so I always want to think about that. But those are the things I guess I'm worried about. Trying to sort out if this is secondary hypercalcemia or primary.
And how would you treat him, assuming this is from his malignancy?
I would pick up the telephone and call for the oncologist on call because I have no idea.
Okay, Dr. Arbulu, hypercalcemia, what do we do? Okay, then what do we do?
Call oncology.
That's cheating. So your differential is like Dr. Whiter was talking. He can have hypercalcemia secondary to his malignancy. Oh, what other cancers do we see hypercalcemia with besides squamous cells?
You can see the small cell. I think what else? Classic. Plasma cell myeloma. I think you could have hypercalcemia. You can have secondary tumors due to hypercalcemia, like brown tumors and things like that. But
so I think we usually think of small cells and multiple myeloma
yeah.
and squamous for hypercalcemia. Yep.
Yeah.
So the other options for a differential will be infection with volume depletion. He could have metastatic disease to his brain, hyperparathyroidism, as you talked, and medication-related hypercalcemia. So, like Dr. Arbulu said, we start with IV fluids and then add diuretics. We have bisphosphonates now, either zoledronic acid or pamidronate. I think most of us use zoledronic acid as treatment. When that drug first became available, sometimes people would dose it 2 or 3 days in a row, and then you get profound hypocalcemia, hypophosphatemia, hypomagnesemia that's just refractory to replace. And the side effects of those drugs can include renal insufficiency and osteonecrosis of the jaw. Dialysis, do we have any kidney people in here? can be used to remove the calcium if you use like a calcium-free bath. And then if this guy didn't have a tissue diagnosis, that would be important as well. So with supportive care, he initially improved and then subsequently died about a month later related to his disease and hypercalcemia with hospice care. This was the first guy I ever took care of that died with a malignancy. And his family brought me a jug of Diet Coke, which was the drink of the day, and an ivy-like plant that I still have called the Mr. Lily plant. So for the last 20 years, that plant keeps on growing. Who's sitting next to you, Dr. Hopkins? It doesn't matter. This is your case, sir. You ready?
I like the hematemesis one better.
All right. This one's yours. 34-year-old white female, past history of breast cancer. Comes to visit her family in Houston. Goes to MD Anderson ER, 24-hour of history, chest pain, dizziness, palpitations, cough, short of breath, and looks sick. Tell me your initial thoughts.
Well, regardless of the malignancy with those symptoms, I'd be concerned about a possible arrhythmia, maybe atrial fibrillation secondary to an infection possibly, but some type of a pulmonary event, either infectious or metastatic disease to the lung.
Okay. On physical exam, she's thin. She's accompanied by her husband and her mom. She's got a little bit of fever. She's got a pretty significant hypotension with a tachycardia, and her O2 sat on room air is 90%. She has distended neck veins that are very obvious. Her chest has bibasilar crackles. You can barely hear her S1, S2. She has decreased pulses in her upper body. She's got a well-healed left modified radical mastectomy scar. Belly is soft, and she has got some hyperpigmentation where she had her radiation over her left chest. So now what other things would be in your differential?
Well, with the neck distension and the distant heart sounds, I would be somewhat concerned about pericardial effusion, perhaps metastatic pericardial effusion would be high on my list, and I'd get an echocardiogram immediately.
Okay.
I mean, other things could be possibly pulmonary embolism, but with the distended neck veins, I'd be concerned about a cardiac event.
Could it not be related to recurrent disease and it's Dr. Hopkins' fault?
What, one more time?
Could this scenario not be related to malignancy, recurrent disease, but could be a side effect of radiation?
Yes, it could be.
Okay, so, because that big article just came out, right?
Yeah, I think I read it last week.
Yeah. So her white count's 4,000, her hemoglobin's 8, platelets are 80,000, her chemistries are otherwise not too significant outside of a low albumin. She has sinus tach, decreased voltage throughout on her EKG. And it was a portable chest x-ray, which was really poor quality, but even with that, she had an increased cardiac silhouette. So now what are you going to do?
I'd still get an echocardiogram.
So that's our differential with what you pretty well said. She got anthracycline therapy plus her radiation, so that ups her ante there. Or she could have an acute myocardial infarction in and of itself with failure. So she got some volume expansion while we were waiting to get that stat echo. The same time she was being moved up to the ICU, where I was a lucky fellow on call. And she got a pericardiocentesis and blood product support. And she was stabilized and was doing pretty good until it came back with positive, poorly differentiated adenocarcinoma, at which time she told us we were all crazy and it wasn't her cancer, and she demanded transfer to a different institution. So we moved her there. So I think, I don't know where Dr. Hallberg went, but we have like 5 minutes, is that right? So are there any other questions or thoughts? you've got a whole bunch of other cases. There are like 15 or so that you can read for your nighttime entertainment. On the very last several pages, there's been multiple concerns from the emergency department about reversing anticoagulation. And so those are the guidelines from the American Society of Hematology that hopefully will help clarify that. Some of the new agents don't have any means by which to reverse them. So hopefully people are looking at that. Yes, sir.
Just really quick on the hypercalcemia case, any contraindications to the biphosphonates, number one, and number two, how soon do you expect them to use them? And I think you may have said this, but when do you, what is an indication after, I presume after you failed to achieve certain level with your hydration and diuretics? Probably you said all this, but.
Yeah, at least I usually give them pretty early up front. Of course, the best way to treat the hypercalcemia is to control the underlying malignancy or cause. That's the best way to control it. And we'll use that as a marker when somebody's on therapy. If their hypercalcemia is controlled on their treatment, that's a sign that their therapy may actually be working. But we use them, at least I do, rather soon. So even if they've gotten their fluids and some diuretics within a day or so, I'll go ahead and dose them. The only true contraindication would be if their renal function was really bad, it might make you a little more hesitant. But if their renal function is poor because they're volume depleted, because what's your first response in your body is to pee out that calcium, and that you think that it's going to be reasonable, then we would go ahead and dose them. The osteonecrosis of the jaw, we send folks for dental evaluation when we have time to do so, make sure do they need any extractions before or not. Sometimes you're going to give one dose just to get things under control and then deal with things later. That's not usually a one-time dose problem. It's a long-term exposure problem for the osteonecrosis of the jaw. Any other thoughts or questions? Yes, sir.
Is steroids helpful for hypercalcemia treatment? Have you done it?
I don't do steroids for hypercalcemia. The data is mixed in whether it's a benefit or not. I don't know whether you do, but I don't think that provides much benefit.
Only in myeloma. Or I shouldn't say, only in lymphoproliferative diseases. It would make sense for lymphoma, it would make sense for myeloma.
Because that's treating your underlying. Yeah. All right. Have a lovely day. Thank you, guys.